All right, welcome back to Anatomy Muscle by Muscle. Today we're talking the deltoid. So you know it, you see it, train it, big rounded muscle that caps off your shoulder. Super visible, another superficial muscle, super important functionally, strength training wise. Definitely one of those muscles that gets a lot of attention in the gym and in the clinic. So we'll go pretty in depth. We'll talk origin, insertion, innervation, function, and then similar to last time, we'll do a little clinical tidbit. The deltoid plays a major role in shoulder movement. It does a little bit of everything, really. It's our go-to for shoulder abduction, of course. Those first 15 to 20 degrees are primarily the supraspinatus, but beyond that, we need a lot more deltoid taking over. So 15 to 20 supraspinatus, but beyond that, deltoid is really the major player in abduction. Separated into 3 distinct parts, they all pull in different directions, so it plays a role in, as I said, a good variety of shoulder movements. Helps with abduction, of course, but also shoulder flexion, extension, internal rotation, and external rotation. So really only missing out on that adduction, that adduction, that pulling your shoulder closer to your body. That's the only one that really lacks. It does a little bit of everything else. So very, very versatile. Also plays a stabilizing role when the arm moves in space. Of course, the rotator cuff probably is the bigger stabilizer in general, those 4 muscles of the rotator cuff, but we consider the big, powerful muscles more of the boss, grand scheme of things. Like, of course, the rotator cuff is going to be the stabilizer, but individually speaking, that rotator cuff is not nearly as powerful as the deltoid. Just a much bigger, stronger muscle. There's a force couple between the deltoid and rotator cuff muscles. The rotator cuff muscles, of course, are going to pull a little bit more down and towards the scapula, but the deltoid is going to pull more up, more of a translation force up towards the head. So a little bit of a balancing act between those two, but the deltoid, of course, is the big, strong muscle of that group. We mentioned 3 different parts. So the parts are anterior, or the front portion, the middle portion or lateral portion of the deltoid, and also the posterior or rear portion. They all insert into the same point, but 3 different origins. This will wrap around that clavicle and spine of scapula, and then all insert into one point. So if you ever see the deltoid dissected out and flattened, it looks like a big triangle. And that's the meaning of the name. Deltoid means triangle. So very cool, very interesting shape and structure. The anterior deltoid helps flex and internally rotate the shoulder. The middle deltoid is big for abduction. And the posterior deltoid is very important for extension and external rotation. It's very interesting for sure. The attachments, the anterior head would attach to that lateral third of the clavicle. The middle portion is primarily on that acromion, so more purely lateral. And then the spine of the scapula is where the posterior portion attaches. So all originate on that clavicle and spine of scapula. Where those 2 structures sort of come together is where you would find the deltoid on your shoulder. All 3 converge and insert into that deltoid tuberosity on the humerus. So there's a bump on the humerus, maybe about 1/3 of the way down, called deltoid tuberosity, and that's where all of these fibers will converge. So pretty straightforward, but it gives the deltoid a very broad range of leverage, control, and, as we mentioned, a variety of different movements. Innervation wise, this one's pretty clean. Just going to be the axillary nerve and that's going to be C5 and C6. There are studies that show that it's primarily C6 here than deltoid, but yeah, that axillary nerve is the primary innervation of the deltoid. Axillary nerve is interesting. It wraps around the surgical neck of the humerus. So anytime we have maybe a dislocation or a fracture, some sort of maybe motor vehicle accident, we do worry about if that axillary nerve is intact. It's a big nerve, it plays a big role, so we keep a close eye on that after major shoulder injuries. We also have some relatively new studies that show at least partial innervation of the clavicular portion of the deltoid by the lateral pectoral nerve. So he took about 60 people, and in those 60 deltoids, we saw that in 86.2% of the cases, the clavicular portion was at least partially innervated by the lateral pectoral nerve. So pretty interesting. But yeah, primarily we're gonna say axillary nerve, C5, C6. The deltoid's a pretty interesting muscle clinically. It's not one that I think of as a very big pathology muscle. It's not usually the main cause of people's aches and pains. Of course, you can have maybe trigger points, some sort of strain, overuse type injury potentially. Maybe if you have an axillary nerve injury, you might see that weakness, you might see atrophy, you lose that contour a little bit. But usually I'm not seeing too many specific deltoid pathologies. Even when I needle, I will needle maybe more of the rotator cuff muscles in conjunction with the deltoid. I think it could be maybe one of a set. Something that is relevant is the difference between a reverse total shoulder replacement and just a total shoulder replacement. The total shoulder is pretty straightforward. You keep the anatomy the exact same, keep that ball and socket, and the rotator cuff muscles are maybe the primary stabilizers, primary control force. In a reverse total shoulder replacement, we flip the anatomy, so we'll see the anatomy totally flipped. So instead of the ball and socket, you have a socket on a ball. They sort of flip the anatomy. They do that when the rotator cuff muscles are just completely unusable, complete severe significant damage, unsalvageable. Those, you know what, we're gonna improve the leverage of the deltoid and allow that to be the major mover. So that's one thing we did stress a little bit in PT school. Just the difference. For a reverse total shoulder, you need an intact deltoid. So yeah, that does it. Quick and easy, quick and easy. Tried to speed up a little bit. That last one took a little bit. Took a little while. So figured we'd speed through, but you know, very important muscle. Big role of movement, strength, stability. Big boy, good looking muscle. Work it out in the gym. So very cool to talk about and provide some insight, some clinical insight. Next up, we're going to do the lats, latissimus dorsi. So that'll be a cool one. And I think after that, we'll probably dive into the rotator cuff muscles. Hit subscribe if you want more of these breakdowns. A little bit of everything, a little clinical input, a little bit of the basic anatomy. So I think good, insightful stuff. That being said, it was fun. We did it. We ran through it. Treadwell DPT. I'll see you later.